Dr. Periyasamy, Professor and Head of the Department of Cardiothoracic and Vascular Surgery, Sri Ramachandra Medical College and Research Institute, Porur, Chennai, has more than 20 years of experience in the field of cardiothoracic and vascular surgery. He has received Dr. Lalita Kameswaran Best Research Publication Gold Medal for the best research publication in a journal with highest impact factor for the year 2015. He was also felicitated on behalf of the Society for Heart Failure and Transplantation by the Honorable Chief Minister of Kerala for having performed multiple successful cardiac transplantations. He has amassed countless achievements, including 3 heart transplants in consecutive days, the first successful TAVI in South India, first successful neonatal ECMO, and the first miniature pacemaker implantation. I request Dr. Periyasamy to start his session.
Thank you, sir. First, thank for organizer and founders. So all of them sitting is most probably MBBS students and post MBBS and medical officers. Based on that recent advances, why we want to know this previous our era. After MBBS, we have to start MS. After that, we have to think about that super specialty. Nowadays, that is almost that cuts down. Post MBBS started, that is direct courses of that is cardiothoracic or plastic or neurosurgery. For that, you're supposed to aware of that, what all the things are happening that is newer. Second thing, when olden days, the difficult to get a surgical seats. Now that's all if you cosmetic, dermatology or ophthalmology or some other, that's radiology. That is a very difficult to get now. Previous era, the surgical and other specialty is very difficult to get. That's why I want to elaborate what all the cardiothoracic newer advances come. Previously, they always tell that it's big surgeon, big incision. Not like that. Nowadays, like Arjuna, the small eye, you can see that big surgeons means through small hole, he has to see everything and facilitate. So today's topic is recent advances in cardiac surgery. A lot of the recent advances happen. The only thing is minimally invasive surgery. The innovation always mother of innovation also is a necessity. This is the age that previously they done, that is sternotomy, Lord Anjaneya. The first sternotomy done in the world. So how that is previous era that doing the cardiac surgery, the small video shown that is some of the open heart surgery. This is echocardiogram view. This is severe mitral regurgitation. So this is the traditional way of the opening. Previously I saw that Lord Anjaneya opened the sternum. Now this entire sternum is open, split open. That's, you see this big spurter. You can see that it's entire, the heart is in front of your eyes. The recent era you can't see that's full heart. We can see where we want to focus that area only you can see. This is the left atrium open. We are inspecting the mitral valve. That is the biggest Cooley retractor. This entire, everything is in front of your eyes. So this is the big incision. Now that era changed totally. So I don't want to go deep into that. Now that is our area's focus is minimally invasive. So how they started minimally invasive, both adult or pediatric. So both we can do in minimally invasive irrespective of the age. This is the traditional way of conventional sternotomy, what we have shown, that is center. That one, then partial sternotomy, then lower mini sternotomy, upper mini sternotomy. The all other three are that we are not cutting the bone full. This is the first one is totally we'll cut split. What is the advantage of the partially preserving the sternum? The sternal stability is very, very important. This is the this is only the sternotomy. Next is the turn to the thoracotomies. We don't cut the sternum at all. We'll almost, that is, we'll go in between the intercostal space. This is the total thoracotomy previously they done. Now that's mini thoracotomy. This is the previous they done. That's inframammary. That's inframammary. That is only the areolar tissue. That size only will be there. So what are the cases we can do? What do you name it in the heart? Valvular or coronary artery? Adult congenital. I am talking about the adult. I'll cover that pediatrics later. Second, that is minimally invasive, what I said. Even though so more minimally invasive, previously that laparotomy, that is gone, that laparoscopy has come. Now that is endoscopic assisted minimally invasive. That incision is very, very small like a areola. Then through that we can deliver that whatever the device has to go, that other things we can see through the only the monitor. That's called endoscopic assisted minimally invasive surgery. This is the port will be there, the small incision, all 3 port we can operate. Next, now that is all that is bread and butter, all pelvic surgery, and that is an urologists are doing that is robotic. Now that's come to the cardiac also. But the Davinsky first introduced for the cardiac only. But the cardiac is only they can go and approach the tissue, that we can't anastomosis. But it's evolved and now that's coming into the pediatric as well as valvular heart disease. This is the robot. So next, what are the things has come? What we saw, that is mini sternotomy and mini hole with the mini hole with the endoscopy, mini hole with the robotic. Then head they gone, if any valve replacement, transaortic valve replacement. They, through the aortic, to the femoral puncture, they gone through the aorta, then reach the arch of the aorta, through the valve, that dilate and implant the valve. So in this, no need to remove the valve, they implant the new valve. So transcatheteral mitral valve replacement and mitral clip. Any age old, the patient is not fit for the surgery, we can go for the mitral valve repair through the mitral clip. Then transcatheter pulmonary valve implantation. 4 valves are there, all 4 valves taken care by the transcatheter newer one. This is the robotic, what we previously said. So what are the adult cases we can do? You name it, what are the adult cases? PDA, ASD, VSD, AV canal, even PAPVC, tetralogy of Fallot and arterial switch. All the cases we can do minimally invasive. Now that's new invention. Why we can't do pediatric minimally invasive? Main thing, no, any cardiac surgery, we have to go undergo cardiopulmonary bypass. We want to stabilize and stop the heart. For that, babies, that small incision, all catheters in the chest, very difficult. Adult, what is the problem? Small incision, you can go to the peripheral cannulation. So what newer that is invented, small incision, we can go the groin, you can approach the intra-abdominal aorta and intra-abdominal IVC. Through that we can cannulate, go on cardiopulmonary bypass, we establish. In the small incision, you can complete the procedure. I'll show that what are the pictures later. This is the minimally invasive CABG. This is the 2 graft we done. You see that is below the mammary, that is a submammary incision, almost 2.5 to 3 centimeter. We are harvesting internal mammary artery. Whatever the procedure is same what we are doing the sternotomy. Only the sternum we are not touching, but the entry point is different. In cardiac surgery evaluation, evolved, the procedures are same, but the entry is different. They were harvesting mammary, internal mammary artery through the left inframammary incision, 2 to 3 centimeter. The mammary artery harvested, divided distal. Proximally is coming from the subclavian continuation. The internal mammary artery prepared. Sometimes a little bit spasm, we'll inject the papaverine inside the internal mammary artery to that is good pulsatility. The pericardial stage suture is taken. You can see that is wherever we want, that area only you can see. If that is previous, that sternotomy I shown, the entire heart is in front of your eyes. The minimally invasive, this is a little bit different. The proximal anastomosis of the vein will always anastomose to the aorta, then only will go to the distal. The proximal anastomosis of the vein anastomose to the aorta. The proximal anastomosis completed. So previous, that is always cardiopulmonary bypass assisted CABG they are doing. Nowadays everyone is beating out CABG. Now that with the help of octopus, what you are seeing, that is the plastic one, that is called octopus. In the down, that is multiple hole will be there. The vacuum put over the heart, it will stabilize that area tissue only. Even though beating out, where we want to anastomose, that area is totally stabilized with the stabilizer. Now that is internal mammary artery prepared, the beveled, then left anterior descending artery open, we are anastomosing end to side. What you are seeing, that is blue one, no? We used to use, that is blood, it should not come in surgical way, we'll use the CO2. Why we are using CO2? CO2 it will absorb. We can't use O2. You can't use O2. So the Lima anastomosis completed. The same procedure will do the PDA. So most of them, they think that right side graft we can't do the minimally invasive because the entry is the left side, the right coronary artery in the right side. But we can, because of new gadgets or innovation, that's all the vessels we can approach. Even left anterior descending or circumflex or right coronary. This is the PDA anastomosis we done. That is what proximal anastomosis of the vein we anastomose now. This is the end of the procedure. You can see that is very small incision. We approximated this submammary incision. This is almost 2.5 to 3 centimeter. This is the coronary artery disease. Even we can do the valvular heart disease, even congenital heart disease. Arnold congenital heart disease, what commonly seeing, that is ASD. Now that is because of the cardiologist well versed with the device. If some of the patient is, the rim of that ASD is not good, they have to go for the minimally invasive or surgical ASD closure. This is the one of the ostium secundum ASD, we are close to the surgically. Instead of the left incision, we go through the right internal inframammary incision, that same small incision only. The procedures are same only. I don't want to go much deeper into that. Next, that is a mitral valve replacement. Same way we will go through the minimally invasive. So that now what we saw, that's all that is adult cases. What are the ASD, mitral valve replacement, repair, as well as coronary artery bypass graft. Now we'll go to the congenital. So congenital is very difficult. That subset, even inframammary or subxiphoid or partial sternotomy. You can see that this is one of the ASD closure for the 7-year-old girl. The incision previously, what that is almost the entire sternum will be there. Now that is 12.5 to, now this came down to 2.5 centimeter. We used to call, that's called band aid surgery. That's what we are, phlebotomy you used to, that is band, no stop band. That one only we used for the dressing. This is a schematic animation, how we go that. This subxiphoid incision, this only subxiphoid split will make a small retractor. Through the same incision, will cannulate the aorta as well as the superior vena cava. So other cannulation through the, what we want to put intracostal drainage, through that, that's lower. Through that, we'll stop the heart, then we'll open the right atrium, we'll close the ASD. The same manner, the procedures are same, only the incision small. So this is a surgical video. Small subxiphoid incision. Sometimes, because this is a little bit grown up girl, subxiphoid is a little bit calcified. We are supposed to use small saw. This is mini sternotomy ASD. The saw that's cutting only the lower, the calcified cartilage. After that, spreader placed. This is sternal retractor. Through that, pericardium open, pericardial, the prepare for the ASD closure. Normally, the ASD closure with the autologous pericardium. Otherwise, you can use the artificial materials, Dacron, PTFE, any materials, whatever the available commercially, we can use. Routinely follow that throughout the world. That's treated by autologous pericardium. This is the autologous pericardium we prepared, treated with 0.6% glutaraldehyde. These are the gadgets, cannula, the aortic cannula, the venous cannula. Through the same incision, previously we are using that is cannula. Nowadays we have gone to the peripheral. Peripheral cannulation even for 2.5 kg also. We can, through that cannulation, you can establish the cardiopulmonary bypass, then complete the procedure. The right intercostal space, that's through that inferior vena cava, the cannula introduced. Through that, the cannula is passing through the intercostal. Keep it ready for the IVC cannula. Now the aorta, same small incision, we are cannulating the aorta for the cardiopulmonary bypass. Yeah, we connected to the cardiopulmonary bypass, that is aortic line. This oxygenated blood is coming from the CPB machine. You can see the bright blood. This is oxygenated from the oxygenator. It's coming as a bright blood. It's go directly. It will take care entire the body circulation. This is the through the same incision we are cannulating the RA for the SVC. Now the IVC pulsing is taken. You can see the right atrium that is pulsatile. The IVC bursting that's open, and that is the IVC cannula introduced to the IVC. Now the connected to the CPCs are good. CPB established. The entire the cardiac blood, no, it will go to the reservoir. Now that is what you are seeing, the black wire, that is fibrillator. So on fibrillation, the heart, it won't beat. Even if you open the RA, no air, it will suck into the systemic circulation. So right atrium open, right atrial stage is taken. So after completing of the ASD closure, you can see the patch. So after de-airing, that is final talk. Why? Because the LA is also exposed to the atmosphere. Some amount of the air in the LA, we have to blow and get rid of all those air out from the LA. Otherwise, put the air embolism, that will go to the circulation. After that, decannulation done. So weaning, after complete weaning of cardiopulmonary bypass, decannulation done. If you see that all the cannulation removed, can see that is complete hemostasis, heart is beating. The lower end, that's one sternal wire we fixed. Because of this baby, normally we won't use the sternal wire. This is the final, that is almost 2.5 centimeter. This is the band-aid. You can see that is band-aid, over that is incision. So this is the baby we operated. You can see that is compared to the nipple, that's almost 0.5, the size of the nipple will be there, compared to triple time or 4 times. So these are the gadgets we used for the minimally invasive. So see, any procedure if you want newly invented or whatever your adventures, what is the motto? Easily has to reproducible. If I'll tell this one, no, someone will tell this is almost heroism. We can't reproduce. What are the things? Now that is because peripheral cannulation are introduced. You can establish the cardiopulmonary bypass very easily. Whatever happened, no, cardiopulmonary bypass will happen. Always will tell that is general anesthesia is very difficult than cardiac anesthesia. Anything heart arrested, call cardiac surgeon, establish on cardiopulmonary bypass, easily can save the patient. Same way, any procedure if you want to easily reproducible. Second thing is safety is very, very important. So, what previous era, what we are doing, that is sternotomy, then entire sternum open, you can see all the sternal wires. What you are seeing, that is inframammary, that is below the nipple, small incision. Nowadays, all the cases are no sternum touch technique. That's, we are not touching the sternum at all. We can sparing the sternum. We can go through this side intercostal space or that side intercostal space, depend on the procedure. So, always that is innovation. Necessity is the mother of the innovation. Why that is all those things coming? This is the one of the baby, almost 2.5 months old baby, truncus we repaired. After repair, we used artificial, that is bovine pericardium. Within 3 weeks, patient developed fungal, the pericardial infections, developed full aneurysm. You can see that the white one is the sternum, below entire thing is that is pseudoaneurysm. Very difficult to approach that aneurysm. Once you've done a sternotomy, that's gone. That's almost, the blood will come out of the heart, the aorta totally open. So that time only, that is on way, almost 2009, we invented that is peripheral cannulation. So this baby, that's already you can see that his previous scar is there. This is the almost 3 weeks later the surgery. So we want to intervene. So what we done, whatever the general surgeon they'll do, same incision, the lens incision we put. Through that, we cannulated the abdominal aorta, abdominal IVC, the small incision. The abdominal aorta, you can see that is, we open the retroperitoneally, we enter, descending thoracic aorta, that's abdominal aorta, inferior vena cava, we cannulated, established on cardiopulmonary bypass, we completed the procedure. This is we published way back, novel cannulation technique for the 2.85 kg. After that, only we started, that is baby also we can do the minimally invasive, even irrespective of age. This is the baby after the surgery. So, all those gadgets are available. Why you want that is bigger surgery? The 2.5 incision is more than enough. It's not 12.5 incision. You can see that a 60-year-old lady, Rekha, is want to 60-year age, want to beauty. Why can't the small baby is with the big incision? So that's why we thought they eradicate the sternotomy, we go to the thoracotomy. So happy, that is what newer, that is invention. What I previously said, dermatology is now that is throwing that everyone in front of eyes, but cardiothoracic also is the cosmetic. You can, that is, can enjoy with any questions you can ask.
It's a very comprehensive and precise presentation, sir. Very good, nice live videos I've seen. Floor is open for discussion. Any questions?
No, before the question, I want all of them MBBS. How many of them want to do surgery, then cardiac surgery? Good. Because cardiac surgery is, everyone that's cardiology is growing, that is, SARS know that, because transcatheter percutaneous has come. Still, after stenting, the cardiac surgery is not there. Now, after that also is there. This is like a husband and wife. This is a triangle, cardiac surgery, cardiac anesthesia, and cardiologist. Like that, nowadays you are all very good opportunity. Direct cardiac surgery is DNB as well as AMCH also is going to come. Because no need to jump over the MS, DNB surgery, then cardiac surgery.
So one question I want to ask, sir. So regarding that hybrid coronary revascularization, so nowadays due to long hospital stay, we can tackle only Lima with LAD, then rest of the things we can go for PCI. How about your experience in that hybrid coronary revascularization system?
I want to show that also, sir. That's if you too much covering, that's we used to do that as hybrid procedures because the Lima, internal mammary artery is the $1 million conduit. You never, that's if you use stent platinum also, you can't compare with the internal mammary artery. Everyone that agrees. But if minimally invasive able to approach the OM or RCA, we can do that. But most of the time, females always prefer the hybrids. Why no? Internal mammary, we put that is minimally invasive, internal mammary artery, LAD. Vein, if you see the female's vein, no, it's horrible. Very small will be there because the nature, the hormone, all those things. The stent is much better than the vein. That's always that type of patient will go for the minimally invasive internal mammary artery, then circumflex or RCA stenting will go. That is very good procedure, combined hybrid procedure.
Recently, one article from Indian Heart Journal, they have published actually from Apollo Hospital, Chennai. They were done study comparing the conventional CABG with this hybrid coronary revascularization. They have found more or less equal, it's non-inferior to like that.
Yes, sir, definitely. Why I am telling no, sir, the vein quality is not good. Definitely you'll go for the thing. Vein also it will come long, but already vein quality is very inferior. Stent is much superior.
Because we have got second generation stent that is more superior.
Yeah,
so
yes.
Thank you, sir. Fine, thanks.
Thank you, sir, for sharing your knowledge and shaping the future of cardiac care.
Finally, we invite our speaker, Dr. Periyasamy. Finally, we invite our speaker, Dr. Periyasamy sir, to felicitate our respective chairpersons, Dr. Sivakumar sir and Dr. Venkatesan sir.